So, all the panelists are here. The number of participants is growing, but I would suggest to start. We have an excellent panel. We have very busy agenda, and in the interest of time and to spare some time for questions also, I would suggest to start. Dear colleagues, partners and friends, I am very pleased to welcome you to the International Women's Day webinar today. To all the women on the line and all those in the world, happy Women's Day, and to everyone else, warm greetings. I am pleased today to co-moderate this session with my dear friend and colleague, Blessy Kumar, a member of WHO Civil Society Task Force, CEO of the Global Coalition of TB Activists, and passionate and dedicated anti-TB advocate. We have amazing, powerful lineup of women leaders in line with the UN theme, Women in Leadership, Achieving an Equal Future in a COVID-19 World. I am pleased to welcome and would like to start from Farandiba Zalika Fatah, ex-DRTB survivor from Indonesia. Tlaleng Mofokeng, UN Special Rapporteur on Health. Shannon Hader, Deputy Executive Director from UNAIDS. Amy Bloom, Senior Policy and Strategy Advisor, Infectious Disease Division, USAID. Marika Winrocks, Chief of Staff from Global Fund. Luchika Ditiu, Executive Director, Stop TB Partnership. Evelyn Kibuchi, WHO Civil Society Task Force Representative. And Amrita Dafrari, Assistant Professor, School of Global Health, York University. Dear colleagues, let's start with some data, statistics. I am representing WHO, and I think that technical agency can always bring our additional power and strength to all our movement and responses with the data, with the evidence. Globally, an estimated 10 million people, as you know, fell ill with TB in 2019, according to the Global TB Report, with women accounting for 32% of those affected. You see, it's not majority, but the burden on this 32% is enormous. We should also keep in mind 1.2 million children, and also all the burden of care and support, sometimes social support, education of the families, because in nature it's family disease, and all this burden frequently is also on women. Women face a range of issues that affects their ability to seek care and get better. In many settings, stigma and discrimination can greatly exacerbate women's social and economic insecurity. In other settings, women face delays assessing treatment due to gender-related considerations, due to a lack of privacy or childcare facilities in healthcare settings. A TB response that is gender sensitive, that's why imperative to tip the scale and achieve health for all and universal access to TB care. More women in affected communities and women's advocates need to be engaged in efforts to design and enhance access to TB services for women and for all. TB prevention, diagnosis, and treatment should form core components of health interventions for women, particularly along their reproductive life cycle. This is vital, especially in the vulnerable settings, in high HIV and TB burden settings. Human rights and equity challenges should be effectively addressed while rolling out the anti-TB strategy to ensure the social, cultural barriers and stigma and effectively eliminated providing women access to highly quality care, free of catastrophic costs and social repercussions. Our webinar's focus, Choose to Challenge, is apt for our discussions today with the women leaders. Through this webinar and beyond, we would like to challenge the current status quo and discuss how we can break barriers to ensure a gender-sensitive, equitable response for everyone who needs it. The clock is ticking. It's time to end TB. With this, I would like to give floor to my co-chair and friend, Blessina Kumar. Blessy, please, floor is yours.
Thank you very much, Teresa, for that, bringing us up to date with the statistics. Welcome to our esteemed panelists. We are absolutely honored to have you all here with us today. And to the attendees as well, a very happy Women's Day. Honestly, I think every day should be a Women's Day. But it's good that at least we have one day in a year where we can focus a little bit on issues that affect women. The UN theme this year is Women in Leadership in a COVID-19 world and moving towards gender equity. As you can see, like Teresa mentioned, all our panelists are leaders in their own right. And when we couldn't think of a better group of people to bring together to share with us their thoughts on TB. We are focusing on TB here in the middle of the pandemic. And, they are high profile, powerful women who have years of experience and have contributed immensely to global health and have agreed to share with us today their experiences and how we can actually change the status quo, because we want to really make a choice to challenge. We cannot sit back and accept what is there today, because we know that more men are affected by TB in terms of numbers, but we know that TB affects women disproportionately. The way it affects women is not just for the woman, but it can affect the whole family. So if we focus on women, we are actually focusing on the whole family. Stigma and discrimination and patriarchal systems in many of the countries means that women continue to get left behind. And we've talked for many years in TB about leaving no one behind. These things shouldn't become meaningless words. I think we need to put substance behind them. We need to constantly keep challenging and pushing forward because the clock is ticking. I just saw Luchika's background. There are so many clocks, and that should actually make us go into a little bit of a tizzy in wanting to, make it happen, because we have no time to lose. We have no time to lose. It is a choice before us. Do we choose to challenge and make a difference? Because I remember as a young program officer, when I asked my boss, when do you want this report? She said, last week. So we can't aspire for something in the future. This should have been done years ago. So today we have a choice to make. And I call on our panelists who have the power in their hands to make a difference, to actually choose along with us, survivors, people who are attending, people who are implementing, policymakers, to actually stand with the TB affected community and actually say that we will stand by and choose to challenge the status quo. Thank you very much. With that, I would like to invite our first speaker who will actually set the stage. Who better than to actually come and share their TB journey with us than someone who has experienced the arduous TB journey. Farah was born in Indonesia, in Purwakarta. She's a young woman of 25. And She comes from a family, she's got 4 other siblings, and she was actually studying to be a doctor when in the 3rd year of her medical school, she got TB. And she went through the whole gamut of things. She had drug sensitive TB, which then became drug resistant TB, MDR TB, and then it went on to become XDR TB. But she fought, she won. She has a tremendous story of resilience. And she says support and love is the most important medicine to fight TB. And let's listen to that. Let's listen to that. Despite the terrible medicines that TB survivors have taken, yet what they say is most important is support and love. Let's choose to give them that. Since TB came to her life, it made a big impact. But she's turned that experience around, and she's joined the Indonesian Young Coalition for Tuberculosis and continues to join us in fighting and ending TB together. So Farah, thank you so much for being with us today. The floor is yours.
Hi, thank you so much, Blessy and Teresa, for having me in this event. Hello, I'm Faradiba. I'm 25 years old and I'm 3-time TB survivor. I'm also currently a medical student and I'm a member of the Indonesian Youth Coalition for Tuberculosis. I'm the only daughter in the family. All my siblings are boys who fully supported me in my treatment. However, there are still many doubts in me, including about how can I catch up on my education and career after 2 years of delay due to my treatment. Even after I was recovering and returned to my class following a long leave, my experience living with XDR-TB still impacts me. After I returned to my studies following my TB treatment, I initially had a number of unpleasant and shocking experiences. I felt like a new student starting over. I didn't know anyone anymore, and everyone in my class was now my junior. One shocking incident when I first returned to class, when the instructor asked, "How do you deal with TB patients?" A male student sitting behind me in class yelled out, "Just let them die." Hearing this, my heart was devastated. How could I let people in my class know that I had TB, let alone XDR TB? If they find out, I will be more isolated and alone. I was so afraid to endure the pain and stigma alone during that time. I contacted my mother to tell her I could no longer continue with my studies. I was too afraid that my classmates would find out I was tuberculosis patient. Some of the saddest was I've been treated have come from other women, such as being underestimated or even abandoned by my female friends who were too afraid to be beside me, even asking me directly if it's okay that we are not seen together on campus anymore. I no longer sit with my friends in class. They left when I needed their support, and I just try to understand their perspective and then forget about it. Through all of this, the only one who was continually reminded by my side is my mother. She has always accompanied me to the hospital for my daily treatment. She has always encouraged me to continue my treatment to the end until I finally completed and was declared TB-free last year. She put her own life on hold, put everything aside in order to take care of me. In my experience, being a woman living with TB has been unpleasant. I believe that other women currently infected with and fighting TB are also experiencing multiple problems and dilemmas in the same way as I did and still do. This is especially true for mothers with TB who are forced to remain distant from their children for some time, or those who are pregnant when they start having TB symptoms and worry about how it will affect their unborn child. When I chat with other women with TB through my Instagram DMs, I can clearly see that they feel guilty for the condition and for the inability to take care of their female responsibilities in the family or work when they are sick with TB. It is really heartbreaking to learn about other women's feelings and experiences from having TB. It is extremely important for global TB programs around the world to recognize, acknowledge, and take action on the additional burdens that TB adds to an already burdensome life for women. These burdens which hinder women in accessing treatment on time and completing it. Despite these challenges and disappointments, I feel fortunate to be a woman during this time in history. There is so much potential for women to achieve in his life, to influence the world in a positive manner and to achieve greatness. Women are the first educators in the family, so the roles of women in affecting positive change in the world cannot be underestimated. Being a woman with tuberculosis, especially as a TB survivor, is quite challenging. Others who don't understand about TB, or even those of us who have it, may perceive that women with tuberculosis are somehow not as healthy or as perfect as women who live without tuberculosis. There are self-doubts that always come up. That it will be difficult to find a partner who is willing to accept our life background. This is especially difficult in some customs and cultures where unhealthy women who have had TB are assumed to be unable to provide healthy children. TB has a significant impact on women's lives. Therefore, it is extremely important that TB global community to continue to assess and support how gender structures and inequalities intersect with lived experiences of female TB patients in order to improve the quality of care for our mothers, wives, daughters, and sisters. So for all women out there, let us unite to strengthen this movement and produce bright ideas to tackle and end TB in the world. Working together, we can be strong and invincible to remove discrimination and stigma that hinder women's step to develop their potential. If you feel abandoned, belittled, never be discouraged, because you are not alone and you will shine at the right time. Once again, I would like to thank Dr. Teresa and Dr. Blasi Kumar, who gave me this opportunity to be able to join this important event, and to the WHO team and GCTA team who made this great event happen. I also want to thank all of you who have supported female TB activities in Indonesia through conferences and other speaking platforms. The presence of events like this can strengthen and unite the voices of strong women to keep fighting to eliminate TB in the world, as well as to improve TB services and fight for women's rights that should be granted, because women have the power to change the world for a better, brighter future with love and tenderness in it. Thank you. Over to you, Blasi.
Teresa?
Yes, Farah, it's really very difficult to say, to talk after you, and your tears, they're very important for us, means more than many words, and we should do our best for you and for the girls like you, and to stop all these unnecessary hardships and crying, and really. It's not only setting the scene, and your example and your courage for us, it's like a tuning fork, and we should check all our activities with people like you to be sure that we are doing right things, that we are moving right direction. Thank you very much, and bless you. With your permission, we will move to our panel. To our eminent panel, and the panel discussion will be undertaken in a Q&A format, with each speaker given 5 minutes to respond to the questions. So, and my pleasure to start asking the question addressing to Tlaleng Mofokeng, our UN Special Rapporteur on the right to health. I shortened your very important title, but it's really a pleasure and honor to have you today with us. And I would like to start with the question. As we all push towards achieving health for all, and how we can be sure that no one is left, literally no one is left behind, and that focus in place on the marginalized first. And in many settings, we know that these are women. Please, Tlaleng, floor is yours.
Thank you so much, colleagues and distinguished guests. And thank you so much for this invitation to share my thoughts with you. I think it is important to start by reiterating the fact that the right to health is interlinked and interconnected with many other rights, alongside rights to reproductive health, bodily integrity, safety and security, as well as access to information. And the right to health is not a right that has to be fulfilled only if people meet certain set criteria, but they are a right that has to be fulfilled, protected, and promoted for no other reason but because people seen that even at our best as a global community, we were never prepared. As specific COVID-19 testing capacity is still lagging behind in some areas, access to treatment and lack of consistent supply of clean water, crucial for the prevention of the virus spread, continues to be a structural deficiency. And so as the pandemic continues to highlight these structural fault lines, we know as well that there has been currently inadequate resourcing of community health systems, biomedical developments, and public information dissemination globally. And so one of the concerns for me is, as the globe, as the health systems were responding to the COVID-19 pandemic, a lot of supplies, including human resources, were diverted from essential services such as chronic disease management, such as TB clinics, such as family planning clinics, towards supporting and resourcing COVID-19 specific wards and admission spaces. And so we know that inequality shapes the structural and systemic challenges that are borne unjustly by individuals, and people who are getting treatment, who are at risk of getting tuberculosis, are just as important and a big component of people who shouldn't be forgotten, as we know that COVID-19 doesn't mean other health-related issues have ceased to exist. And it's through differential access to healthcare and underlying determinants of health, socioeconomic and other structural factors, and how they interact with each other to generate and reinforce negative health outcomes that disproportionately affect people. And we already know there are people who are already living in vulnerable situations even before COVID-19. And therefore we must be vigilant to policy changes that leads to further marginalizations or violations of the rights of people in vulnerable situations who are often already neglected from health services, goods and facilities, people who are living in peri-urban and rural areas, women, disabled people, older persons, internally displaced people, people who are living in overcrowded settings and residential institutions where we know incidences of TB tend to be higher. And of course, people in detention, those people experiencing homelessness, migrants and refugees who are often cut out from local health services because they don't have documentations, and of course people who use drugs, LGBT and gender diverse persons. And I think it's by centering those people that we can ensure that we truly leave no one behind. And as part of my role as the United Nations Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of both physical and mental health, I'm intentional on bringing to the international human rights space a deeper understanding on the negative impact of coloniality and racism and oppressive structures that are still embedded in our global health architecture, from the types of health programming to the type of financing and the clauses that come with foreign aid. And we know for a fact that it's usually the people, Black people, indigenous people, and people of African descent, and those who are in the so-called developing world who are disproportionately impacted by these structural oppressions. And as much as I'm a sexual and reproductive health rights expert, I do know that young people are also at risk of getting tuberculosis. And one of the ways that I think we can look forward post-COVID, if there's ever such a time, is by incorporating and digitalizing health, but also making sure that the digital innovations and interventions that we come up with do not perpetuate or deepen existing inequalities, because artificial intelligence and digital technology is not neutral. We know how many of the sexism, racism, albialism, homophobia can be embedded in some of these technological advancements if they are left unchallenged. And so just to say that in my mandate, in my tenure, I do aim to focus on communicable diseases and their impact on young people specifically, as well as women. The mandate and the scope of the mandate places upon me to look particularly at vulnerable situations and vulnerable groups of people. And I know firsthand how women face obstacles to the enjoyment of their sexual and reproductive health rights. But this can be true for a spectrum of illnesses across the health sector, whether it's at the national level, whether it's at the community level, whether it's an obstruction or an obstacle due to policy and laws. But we do know that these advancements and the use of technology and interventions are key, not only in making sure that people can get and get automated appointment systems, that their patient files and management is kept properly, so that there can be a seamless referral in between the primary healthcare and secondary and maybe even tertiary healthcare, and that even medication for people, they can have access up to 3 months or 4 months of treatment, as opposed to having to come in every few weeks to this to the healthcare facility to get their treatment. And so in my work, I know there's a lot of interagency frameworks developed by the WHO, UNFPA, that provide a guidance and principle on effective planning, development and implementation of digital solutions with and for young people to address the many health challenges that they face as they grow into adulthood. And therefore, it's important that all of us draw on the many experiences that we have in our organizations and individually working in the field, but allow young people themselves to be at the table to set the agenda and to set the goals forward. We know that the SDG 2030 is the last decade, and many people are forging forward and trying to go ahead full steam. But COVID-19 has meant that it has basically given us, all of us, a shock to the system. And so as we create and implement, we have to be thoughtful in how we create sustainable and effective health solutions and interventions for young people. And I think all stakeholders must use a human rights framework and use tools that are embedded in human rights. And of course, being transparent is important because that builds trust and that leads to accountability for the many communities who depend on the states. And of course, in closing, just to say that, states do have certain obligations to fulfill and to protect the right to health, including the right to health of those individuals who are at risk or those who already have tuberculosis, and that we have to remove the oppressive systems and conditions that continue to marginalize individuals. And we must adopt a collective vision for a world and communities that we want in the future that uphold human rights, that use intersectional frameworks as a bridge to justice. And whether it's before, during, or after a public health crisis, such as the COVID-19 pandemic, we must know that we shouldn't have communities that place people in vulnerable situations that leads to rights abuses. And we have to protect and promote the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Thank you so much.
So thank you very much, Dr. Tlaleng Mofokeng. You are really carrying very important mandate and doing very important job. And we should be all together, especially in this time of challenges. And we are all learning from this COVID-19 pandemic. And you brought very important issues. Probably I didn't hear before. About, of course, we've heard, but no one brought it so clear that digital technologies can bring us opportunities, but also they can bring some challenges. And also another important fact, women are not only among the most vulnerable and affected, they're also among those who are contributing a lot into the response. And in the current situation, we can see that 70% of the health workers, the social workers are women also. And it should be recognized, respected, and also they should have adequate salaries. But salaries are still much, much less. And this is also a fact. So, of course, we can do more, and we will be happy to continue working very close and jointly with you. Thank you very much once again. With this, I will give floor to Blessina.
Thank you very much. I'd like to also add my own thanks to Dr. Mofokeng for bringing out the challenges so clearly. And you said we were not prepared. COVID really caught us off guard. That's so true. But the reality is that we know TB. We aren't caught off guard. So I think it's very important for us, like you said, to safeguard the gains that we have in TB and not, not push it to the back burner. So we stand with you, the affected communities, and we have great hope for you to actually choose to challenge and change the status quo. Thank you.
Blessy, I'm sorry. Blessy, I'm sorry. We see hand raised by Dr. Tlaleng. You would like to add? Please.
Would you like to say something? Your hand is raised.
Mm-hmm. So probably we will come back later.
Yeah. I'm really delighted now to welcome Shannon Heder. I hope I'm pronouncing that right. Shannon is the Deputy Executive Director of UNAIDS, and she brings to the position more than 20 years of international experience in global health and responding to HIV and infectious diseases, strengthening health systems. And she's served in key health leadership roles, emphasizing accountability, scale, and impact for sustainable responses. And Shannon, thank you so much for being here with us. The question to you is, we in the TB community who have come from the HIV world always seem to compare and keep saying, oh, but it worked in HIV. Why can't it work here? Things seem to move so smoothly. Why are we struggling in TB so much? So the whole response is a little bit different. So how can the TB response be more gender transformative? Mm-hmm. And what are the lessons do you think that the fight to end TB can learn from that rich HIV response that we all have experienced? Thank you. And you have 5 minutes.
Great, thank you, Blessy. Thank you, Teresa, for inviting us to participate. And wow, coming after Farah, Dr. Farah and Dr. T, what a fantastic way to kick this off. Thank you for sharing your personal story, Farah, and thank you for addressing all of our human rights principles and SRHR basis that we need to take into account, Dr. T. So when it comes to whether it's HIV or TB, what are the things we need to think about in terms of gender if we're really going to be gender transformative? And I think first and foremost, we have to think very intensively about gender itself. We have to think inclusively about gender. Yes, it's about women, and it's also about men. It's also about women in all their diversity, women who are transgender, people who are non-binary. We heard from Teresa as we started, we know men's TB rates worldwide is a burden of disease and a burden of the deaths from TB, and seems to suggest, you know, not all the health-seeking behaviors we might want to be able to have early and rapid diagnosis of TB. When we think about gender, we have to think about how transgender women or men are treated in the healthcare setting. And how does that impact being gender transformative? We have to think about intersectionality, that each person is more than just their HIV status or their TB status or their gender identity. It's how those things intersect with their other factors: poverty, crowding, built environment, work risks and exposures, hunger, key population status. You know, it makes us ask, how is a woman who is a sex worker treated by healthcare settings? And what's the impact of a new diagnosis of HIV or TB on their work? How about a woman who's a mother? Will she receive both what she needs for her own health and also what she wants to protect her children if she's accessing HIV or TB issues? We have to look at the person holistically if we're really going to be transformative in our gender approaches. And even then, you know, what is it to be gender transformative? I think, you know, we've heard a little bit today already for International Day of the Women. Even when it's about men, there are impacts on women. There are, for TB and HIV, there are economic and social impacts on women and families, social impacts of catastrophic costs for TB and stigma surrounding perceptions and misperceptions of what it means to have TB. We heard from Farah that caregiving responsibilities disproportionately, of course, right? We're so used to this, fall on women. And we've heard about some of the challenges around children. What if you're worried about having your kids taken away from you because of your illness, or are unable to access, let's say in TB preventive therapy for the kids? Because we know that's not happening very often in our settings. And I think, as we know, that in some settings and in some countries, the non-health impacts for women with TB are extraordinarily severe. I think there's an example: more than 1 million women and girls are diagnosed with TB in India each year. And although more men are affected by TB, women experience the disease differently. Women might be particularly stigmatized, unable to find a partner, abandoned by their partners or husbands, or dissuaded from having a family. So how do we move from gender sensitive through gender responsive to be truly gender transformative, which is considered the WHO level 5 for gender and public health? You know, gender sensitive might be you have a comfortable clinic or a waiting environment or provider matching by gender. For example, we might not have men wait in an ANC clinic to access their TB services or their HIV services. To get to gender responsive, we might make services match needs. For example, having a clinic that's open outside the normal work hours for a typical workday for one gender or another. But then to become gender transformative, we really have to go to these root causes. We have to, for example, overcome concepts of masculinity that get in the way of health-seeking behaviors that would be helpful for men and for the whole family. And so let me just address a few of these. One, health-seeking behaviors. We know that toxic masculinity, fear of stigma and discrimination, both socially and at work, fear of catastrophic costs, all of these factors for TB you know, can really affect our health-seeking behavior among men. And those things really lead to lower testing and treatment and care, which has huge impacts on women, on families, on communities. Longer time to diagnosis, outcomes, more infections of others. And even when men bear a disproportionate share of TB disease burden, women bear the social and economic costs as the de facto unpaid caregivers and keepers of the household and community. Another issue to think about if we're really going to talk about being gender transformative, decriminalization. Decriminalization of someone's gender identity, of their key population status, thinking about what it means for women who are incarcerated or detained. How do we address these larger issues of the society and criminal status that are going to affect healthcare seeking behaviors and attaining them access for both HIV and TB? And then one other example to think of is gender-based violence. We know in many cases, women living with HIV, some women have worries about their safety, have worries about intimate partner violence. We know that having a new disease or a new diagnosis isn't going to help violence. In fact, we're seeing in COVID-19 an increase of gender-based violence around the world and an increase of intimate partner violence. We're not going to address this risk for gender-based violence only by giving diagnosis of the disease. So if we want to be gender transformative, we need to reduce this barrier in society to effective family communication strategies for your own health and well-being and for the family. So what do we learn from HIV? Well, the good news is that gender transformative interventions in the HIV response give us better outcomes for women and for men. Gender assessments in Africa demonstrate that adolescent girls and young women can experience sharp reductions in HIV risks with multisectoral HIV responses that are rooted in transformative action on gender equality. Yes, focusing on women and girls' health, but also their sexual and reproductive health, their education, their economic empowerment, their anti-hunger or sufficient food, their safety from violence. And we know that these interventions that are gender transformative empower men and women of all ages to make informed choices, to engender mutual respect and safety, to benefit their families and communities. And these lessons can be applied to the TB response as well. They've got to go beyond just the TB and the HIV and require an integrated approach across health and development if we're going to end AIDS and end TB by 2030. Thanks.
Thank you so much, Shannon. That was really good. I really, I think it resonates with us when you talked about gender transformative means it's a win-win for everyone. And unfortunately in TB, we don't hear so much about gender-based violence, but we see women on a daily basis who are abandoned the minute they are diagnosed with TB. So I think it's, you really touched on some of those very important things. And we really look forward to UNAIDS working together with us on this journey to end TB. I think we cannot not do that. We would also like you to work closely with the TB affected communities so that, we can inform the way the response is designed. So thank you very much for that. And with that, I'll hand over to Teresa.
So thank you very much, Blessina. So, and I would like to turn to another outstanding panelist and speaker, my colleague and friend, Dr. Amy Bloom, Senior Policy and Strategy Advisor on from Infectious Disease Division, USAID. And my question to you will be specific, but I know, Amy, that you have a very broad vision and a rich experience, not only in TB, also in HIV. You were very active during different outbreaks of communicable diseases, and your vision is really broad, and you know a lot from the perspective of history, labor, justice, and all these things. And that's why I am sure your response will be very important and covering a very broad area. So, but I would like to start with very specific and concrete things. How can donors be more cognizant of a gender-sensitive TB response? What lessons can be learned from USAID's support to countries So what we can do differently together, and what are your perspectives? Thank you. Floor is yours.
Thanks, Teresa. And thanks to all the panelists and everybody on who's listening and will be working with us. But it was, I think so far we've heard very powerful interventions, and I really appreciate that. And we'll try to, we only have 5 minutes, so I will try to hone it down a bit. But I think when I was thinking about this last night and then this morning also when I was hearing what people were saying, I don't know that the question is, how can donors be more cognizant? I think people are pretty cognizant is on the donor side. I think the question which faces us is, how do we use this understanding to mitigate the impact of gender and better support our programs? The first thing I'll say is, I think it's extremely important that the UN high-level meeting did address this and did include this. Of course, we need to make sure that we do this at every level, but the fact that we have this imprimatur of the high-level meeting saying we need to include this, I think frees up countries to focus on this as well. And I think that's extremely important. The second thing I would say is I think we've really learned, and God knows we've had enough time to learn this, so I'm glad we have, is that we need to ensure a tailored, culturally appropriate response. We have to know our customers. Why should we assume that what works for men works for women? I mean, we see this all the time in health and outside of health as well. And you know, why would it be that something in a rural area works in an urban area and an urban area works in rural? That's not the case. Well, why is it that men, what we focus on men all the time, why would that work for women? We need to do things that work for women. Women have very, and we've heard some of this, women have very specific issues, and there are factors that go way beyond health itself. You know, education and literacy, freedom to seek care, freedom to make decisions about your own personal care, not someone else, not a husband, not a mother-in-law, not anybody else, but you make the decisions. And also the concept of women having as much value as men. I think that is the opposite of that is quite pervasive in many places, and that impacts how women get their care. There's a second role, and it was also touched on, and that's the role of caretaker that women have in our societies all across the board. And I think this can potentially lead and has led to women neglecting their own health, and also as they tend to others, that's how women are seen. They are often talked about as, I have to say, vectors of disease. How does this affect their children? How does this affect the men in their lives? It is not the focus on women. And I think we have learned that unless we do that, we're not going to get anywhere. Women are not vectors. Women are on the receiving end of disease as well. And so it's not just about women. It's not just about the ethics of equity. It's about an effective response. An effective TB program cannot happen unless these things are on the table and that we address it. So what kind of things has USAID been doing? Well, I would say first on the sort of the smaller, on our country level, for example, you know, when we put out a request for proposals, every single one of those includes a gender segment. That is, how are you assessing the issue of gender within this? How are you then going to address that? What are you doing to really focus on that as a key component? And once something is, if someone does do a program, we actually assess that each year. We look at what kind of progress are you making? And then what kind of course correction are you doing? And I think that we often find that people see this as a checkoff. Oh, we have to do gender. That is not acceptable. Because again, it's not just about ethics. It's not just about women's health. It is about success as well. And I think that sometimes we have to change how we talk about things in order to make these things happen. So that's, I'm just an example on the sort of country level, but we also obviously support many more broad global kind of initiatives. which also not only are global, but are then adapted to country level. And I think those are very important. The support of activists and the community, and now, most recently, to make sure that there's actually also a focus on women in that community, and that women can get together and discuss things. In addition, we have been supporting now through Stop TB Partnership, a TB CRG investment package that helps countries integrate this gender approach and be able to integrate that into their funding requests and to achieve the UNHLM commitment. This includes a how-to, unpacking what it all means, as well as assessments, and also how do you go, what's the next step? And a number of countries have already done the assessments. I think it's 20. But we also need a costed action plan. And 5 have done that, because we can assess, we can talk about it, but we need absolute plans. And so the other thing I just wanted to talk about, a couple of quick things, is we need evidence. We have been talking around this issue. We all know it's important, but without evidence, we really are just talking. And I think that that is incredibly important to change the status quo. And we need this to change the interest level and political commitment at every level. We need it for the global level. We need it when we talk to ministers, but we also need to make this important at the delivery level, all the way down there, because we can talk about it, but unless women are actually seen as key components of the response, it isn't going to happen. And I would just close in this by saying that women need to lead the way. I think this is not going to be ceded to them, this important issue. And it's not necessarily a problem always of keeping women down or keeping them in their place. There's often an element of that. But really, it's the fact that if it doesn't affect someone directly, they often don't even notice it. And that's why diversity in the response and making sure women are in leadership positions in this is key, because they aren't going to forget it. It does directly affect them. And I, as a donor, we're going to continue to support these efforts. And actually, we're working across our agency with the gender, our Office of Gender, as well as across health, where people are working on maternal issues and all that, to make sure that this is front and center. Because as I said, it's not only an equitable approach, but it is the way we can get to the answer that we want. We want to eliminate TB. You can't have one without the other. And I'll leave it at that, and hopefully happy to answer questions or discuss with people. Thanks.
Thank you very much. Amy, can't agree more with your points, and I'm taking also your requests and for the evidence also as a specific request to WHO. Of course, we need more evidence, and we should not only request or commit, we should be factual, we should be evidence-driven, we should monitor, and we should be able to present the case, and it can bring us power, more power to our requests. So let's continue, and this discussion is much broader, neither talking about specific problems of women. We are coming to the broader perspective of the equity, vulnerability, access, and when we're talking about people-centered approach, it's about approach which will be the best for women, for men, for transgenders, for all. So that's why let's continue our discussion, and we'll try to find the best solutions. I will sure that we will do it. So with this, I'm giving floor back to Blessy.
Thank you, Teresa. And thank you, Amy, for those very, very interesting points that you put forward. I would like to now invite Marika Winroth, who is the Chief of Staff of Global Fund. And Marika, since joining Global Fund in 2013, she's brought all her 30 years of distinguished career in global global health to the Global Fund and has had a focus on gender and human rights, which really makes her the right person from Global Fund to be speaking on this. And Marika is also a very dear friend of the civil society and the affected communities. Marika, thank you so much for joining us, and the floor is yours. And the question to you is, how can we encourage and sustain gender-sensitive TB responses by ensuring prioritization of funding requests that include gender and equity considerations? How has the Global Fund addressed this? Over to you.
Thank you very much, Blessy. And thank you for you and Teresa for organizing this really important session. And it's really nice to see how the messages of the different speakers so far are really coming together and are super aligned, which probably is not surprising. Ensuring gender equity in TB starts with gender responsive research agenda and investment in TB. In 2019, and others commented already on it, around 2.5 million women fell ill with TB, and close to 500,000 women died of TB. Given that TB is a preventable and curable disease, that's a startling figure. While it is true that men account for 2/3 of the notified TB cases and are more affected by pulmonary TB, we know that extrapulmonary TB disproportionately affects women. However, the national TB responses often focus on the pulmonary TB, leaving a gap in surveillance, diagnosis, and treatment of extrapulmonary TB. We also know that while men are more at risk of contracting and dying from TB, there are also complex dynamics on risks and access to services that I think all the previous speakers have spoken about, that are barriers to women receiving TB treatment and prevention services. There are reports and studies showing how women are disproportionately affected by stigma, discrimination, and violence due to their TB status, and how the burden of care falls heavily on women and girls. And Farah Diba's moving story was a clear illustration of that, how she herself had to struggle with stigma and discrimination, but also how her mom put her life on hold to support Fariba through the struggle. Very glad that your mom was there to be with you, Farah Diba. And studies in rural South Asian countries also show that less women sought TB services through qualified healthcare practitioners, and more women prefer traditional healers or alternative medicine. Many factors can be attributed to this: lower levels of education, knowledge on TB, lower socioeconomic status, and high levels of societal stigma and discrimination. Gender equity is relevant across all aspects of responses to TB, be it case detection, diagnosis, treatment, and prevention for both pulmonary and extrapulmonary TB. And it's a critical factor in identifying the estimated 2.9 million missing people living with TB who went undiagnosed, untreated, or unreported in 2019. Through the Breaking Down Barriers initiative, the Global Fund invested $123 million to remove human rights barriers in the last funding cycle, 2017-2019. The initiative helped to catalyze increased investments in programs to address human rights and gender-related barriers, and helped communities, civil society, and governments to identify the root causes of human rights and gender barriers, determine what is needed to tackle them, and how much that would cost. The Global Fund also supports several TB communities, regional platforms, and networks, including the African Coalition to Fight TB, ACT Africa, in its use of a gender responsive agenda to address TB in sub-Saharan African countries with the highest number of missing people with TB. The coalition integrates gender approaches in interventions such as strengthening community voices in national TB programs, training communities in gender assessment tools, planning TB programs, and developing community-led strategies for finding missing people with TB. The Global Fund requires countries to identify the human rights and gender-related barriers to effective national TB response and address those within their national strategies and funding requests. And Amy Bloom described a similar approach for USAID. In addition to conducting gender assessments, which were supported through the strategic initiative on finding missing people with TB and ensuring that recommendations influence national programs and approaches, gender equity and equality can be advanced through a wide range of programs, especially programs that are transformative and empowering. These include supporting networks of women with or who survive TB to strengthen community-led responses and increasing access to justice through community legal empowerment. The COVID pandemic has exacerbated barriers of access to treatment and left many women and children especially vulnerable. The Global Fund remains committed to human rights and gender equality and will be guided by this commitment in its decision-making around COVID-19 and how best to adapt its operations. And as we prepare to celebrate World TB Day later this month, we must not forget that rights-based and gender-responsive approaches are fundamental, not nice-to-haves, for countries to effectively respond to both the TB epidemic and the COVID crisis. Thank you. Back to you, Blessy.
Thank you very much, Marika, for that. And I think, as communities, as civil societies, and as governments, we are very dependent on Global Fund to do the work we are doing. And I'm really happy to hear you stress the importance of legal support mechanisms where women can access legal support, and the emphasis on human rights. I think a rights-based response is what is going to actually lead us to seeing the end to TB in the near future. And I was very happy also to hear you say people at the center, which resonated throughout the partnership forum as well. I think that's a very important aspect to this. So thank you very much once again for being with us. And with that, I'll hand over to Teresa.
So thank you very much, Blessing and Marika. And my next question will be to the person with whom probably I'm interacting and talking after my GTB colleagues and my own family the most frequently. It's Dr. Lucica Ditiu, and from Stop TB, Executive Director from the Stop TB Partnership, my very good colleague and friend. And we've just had another, prior this meeting, another amazing meeting, excellent panel of TB warriors, women. And I'm looking at your clocks on your background, Lucica, and thinking, so it's such a pity that we have only 24 hours, 24 hours for World TB, for World Women Day, as well as for World TB Day. And it's not possible to cover all important topics, but it's not the beginning, it's not the end, it's just continuation and another opportunity. Lucica, I would like to ask you, how is the Stop TB Partnership and its network of partners promoting a gender-sensitive TB response across all levels?
Yeah, so thank you very much, Teresa. And yes, it's awesome that we are able to speak openly. And, I feel this year's, not just this year, but last year, the year before, that we are really shoulder to shoulder, at least, most of us here in this call, but thousands of others. I think the TB movement is finally taking some ground. I want to add something that you, Blessy, mentioned when, COVID hit us and found us unprepared, but you said, but we know TB. And I'm sorry I start my intervention with this, which was not my question, but that's exactly a very good point, because COVID is an airborne disease, is an airborne infectious disease. It has similar way of transmission, it has similar diagnosis, it has even similar symptoms. If we want to build anything for global health security for any airborne disease, it's a different story if it's a digestive pathogen or so. If it's airborne, construct on TB or construct with TB, that's the only answer, because the infection control, diagnosis, contact tracing, active case finding, community support, ensuring no stigma, communicating about it are all similar. So this was a parenthesis. Then thank you, Teresa, for the good points. And indeed, it's great to be colleagues. It's great to be friends. And I think as women, speaking about time, you see, we all try to do a lot of things in a limited amount of time. And I think very different with the men. This is not to say anything about them, but if for us, some people say we have to finish some things today, and there is a certain number of hours. I tell you that we are trying we neglect ourselves, anything else to achieve all of that. Can be, you know, if a kid come to us or a neighbor saying, I need your help, cook something for me. I tell you that I imagine probably all of us will drop everything, will drop timing to go to bed or things for us to do our hair, and we will cook or we will do that thing. Is that nature of nurturing that women are having very often more than than the men? But this is to say that I think most of us feel the pressure of this clock ticking more than others probably, and we feel it, the urgency of it and the urgency to deliver. As the Stop TB Partnership, there are many things that we were doing. I'm very grateful that Amy, coming from USAID as our main donor, and as well as having a big vision in terms of engagement of community rights and gender, are really supporting us in these efforts, as well as Global Fund. Maraika spoke about that, and Canada. So we did, actually, we had specific rounds of TB Reach looking at women empowerment, amazing work happening there, as well as funding through TB Reach, but as well Challenge Facility, groups of transgender, including in India and Pakistan, that was really unheard of when we started about that. The same time, as you heard, we have a series of tools to do the gender assessments in the countries, but not to stop there, because it doesn't make sense to have an assessment that say, oh, things are not working. Amy very clearly pointed out to this. The 2 points that I want to add, because I am aware of the timing and everything, are Teresa mentioned, and most of you are aware of the creation of a network called TB Women, and every woman should be part of it if it has anything to do with TB, as a survivor, as a fighter, as a participant, as a person with a heart in there. Is the sort of unleashing the power of women to fight TB. And it was a very emotional moment today when it was launched, because this was the work driven by the TB survivors, by some amazing women from all around the globe. And it was emotional because they also developed a strategic plan and the vision, very robust conversations. And it was amazing, the feeling of unity that we had there, and I feel here as well. So we are supporting these pieces. And we try as well as Stop TB Partnership, we kept the role of women and the empowerment of women very close to our hearts. And there is a group that is monitoring organizations globally. This year they monitored, it's called Global Health 50/50, monitoring 201 organizations, and we are in top 5% of them in terms of women inclusion and empowerment and leadership, which is really very good, because we speak here of very large, very well-established organizations that are monitored for longer years than we exist, and much larger than what we have, and so on. But we are very proud to have this. Ultimately, what is important is that we have a common agenda in making this world a healthier and better place. If we are able to drive and support women at community level, actually at any level, somebody said in the other call that other generations are looking at us, and Faradiba, you are probably, I don't know, maybe you are the youngest here, we should be having no fear. We should not be shy. We should not be feeling excluded. We should just demand what we feel is important and we need, and we should do that with no hesitation, and with no shyness. Sometimes we are like, oh my God, what is going to happen? What will be said? And I'm the first one I'm the first one in my house going to a university, and everybody was in my family very, very emotional about that. And there was, you go this year, or if you fail this year, you are not going at all. And you feel the pressure, but you say, I'll just go ahead. And it's not easy, but we have to get out of the comfort zone, because unfortunately, it's not offered that easy to women. Somebody was speaking today philosophically to me that maybe we don't need any more Women Day because we already are achieving what is needed. I said, the plan is to achieve, but we are not at all there. And education and health is having a lot of barriers for women, unfortunately, globally, not just in TB, but in general. So I know that I did a big soup versus what Stop TB is doing and some personal reflections, but I felt like very welcomed because I see here faces of my friends and colleagues with whom I meet, and I share the same, you feel comfortable to say what you think. So Teresa and Blessy, thank you for putting together this amazing group of people led by you, amazing people, and thank you so much.
Thank you very much, Luchika, for your passionate as usual speech, and you are doing a great job, and it's a real challenge for you to describe everything in 5 minutes, what you are doing. And thank you for reminding and bringing again our attention to some similarities between TB and COVID. We were still wondering why, despite of our that we are repeating, bringing it again and again, it's not so much attention to these things. And of course, it's important to respond to the new threat, but new threats are coming and leaving, and luckily their life cycle is much shorter than TB cycle. TB exists already for the centuries, and it will most likely, unfortunately, remain with us. And that's why I think that looking how TB programs are contributing also into the COVID response, given these similarities in diseases, we can build stronger TB programs. It should be one of the lessons learned from this COVID, and these strong TB programs can contribute also not only for TB response but also for COVID response. So let's continue learning lessons, and let's try to do our best in future. And over to you, Blessy, again.
Thank you, Teresa, and thank you, Luchika. Always happy to hear your passionate words of pushing us forward. Thank you for that. Next, I'd like to call on a dear colleague and friend, Evelyn Kibuchi, who is a member of the WHO Civil Society Task Force along with me. She is also the National Coordinator of Stop TB Partnership in Kenya, and also the Regional Director of Africa TB Caucus, so works with a lot of parliamentarians, policymakers. And Evelyn, the question for you is, what role can the civil society play in supporting countries to develop and implement gender-sensitive, equitable plans? And if you could also just share some of the lessons from the work undertaken by the WHO Civil Society Task Force and the members in the different countries we all are from. Thank you. Over to you, Evelyn, and thank you for being with us. You have 5 minutes. You're on mute. Can you unmute yourself, please?
Thank you so much, Blessy, and thank you so much, all the other panelists. Before I bring up the role of civil society and the lessons that we have learned from the task force, as a civil society task force, allow me to just share these 2 stories that I've come across that shine more light on the effect of TB on women. One of them is called Beatrice. When Beatrice got married, she, like any other woman, was very excited and looking forward to getting a child and holding that bundle of joy in her hands. But 2 years into a marriage, Beatrice had not conceived. Instead, she started suffering. She was hit by some condition which was characterized by painful abdominal pain, sweating at night, and general malaise. She visited a number of hospitals, but none of them could diagnose what the problem was. Coming from a community that really believes in a lot of cultural practices, the in-laws, of course, started whispering behind her back, wondering why, after 2 years, is this woman not giving birth? And Beatrice comes from the community I come from, and we believe that if your parents or your grandparents never met all the cultural obligations, it could affect your capacity to conceive. And this is what the in-laws interpreted. And so Beatrice was told to go back home, find out what your grandparents or your parents never did that is making you not conceive. And going, she did. Fortunately, the medical reports came back, which revealed that what Beatrice was suffering from was TB of the uterus. And that was the reason that she was not conceiving. She was lucky that the disease was identified, and she was put on treatment like for 9 months, and she got cured. But to this day, Beatrice has not conceived. Her marriage is hanging on the balance. Catherine, on the other side, was not very lucky. When her 3-year-old son got infected with tuberculosis, the husband said, from our community, we don't have this disease. This disease runs in the genetics of your family. So go back, get your disease treated from where you come from. And that's how she lost her marriage. And today, luckily, Catherine decided to experience for advocacy for community education. And as we are talking, she's a community health worker in Nairobi, where she specifically educates people on TB so that it's not mistaken to be cultural disease or a genetic disease, but a communicable disease that is treatable and is curable. Having given that to those two stories, you can see that much as we are told, that data shows that men are more infected by TB, women suffer more. On the gender perspective, women suffer more from the disease. And a lot has been said by the speakers who have spoken before on the relationship between TB and women. Issues have been mentioned about the complications of TB in pregnancy, how pregnancy may affect, how TB may affect the outcome of a pregnancy, from low birth weight and side effects of TB treatment while a woman is pregnant. We also have issues of genital TB that is associated with infertility in women. And infertility is highly stigmatized in many communities, and often it is blamed on the women. Like in the case of Beatrice and the case of Catherine. I will quickly, I'll also mention about some of the factors that places women in that position as far as TB is concerned. And I know a number have been mentioned. For example, the stigma that is associated with tuberculosis, the socioeconomic factors which have an impact on access to tuberculosis, to services for tuberculosis. Women are known to suffer from disproportionate poverty and low socioeconomic status, access to, less education, all which are barriers to healthcare. And these are factors that really make women more vulnerable to tuberculosis. But also, talking about the socioeconomic factors, from where I come from, or from where I sit, you find that women are likely to take longer to seek treatment more than men, because sometimes they have to get permission from their husbands or from their partners to seek treatment. Sometimes they're taking care of their children and they cannot leave their children to go seek healthcare, and so many other cultural and socioeconomic factors. And now jump into your question. What is the role of civil society and us as members of the civil society task force in this gender issue, especially for TB and women? Civil society and the task force have to do what we do best. And this is advocacy, advocacy, and more advocacy. Advocacy for what, you may ask? One, we need to be very strategic or very purposeful in advocating for resources to address these barriers that stand between women and TB health, access to TB services. And a previous speaker has mentioned about the need to invest in these barriers, in addressing these barriers. Secondly, we are not to do a lot of, to engage in a lot of advocacy to ensure there is good policy environment to implement some of these interventions. And as civil society, we need to take it as our role to ensure that there is proper policy environment, both at our country level and at the global level. Human rights. Not having access to human rights is such a huge barrier to access for TB services among women. And like I've mentioned in those two issues, those two cases, there's a lot of violation of human rights that led to these women suffering because of TB. And it is the role of civil society to, one, look at what laws are in place that are not being implemented and what laws need to be implemented to ensure have violation of human rights. I was excited when Amy Bloom mentioned about the fact that the USAID has been funding research on community human rights and gender, and she mentioned about having this survey conducted in about 20 countries. And as civil society, we need to advocate for this sort of studies to be rolled out in all other countries that have high TB burden, so that we're able to know exactly what barrier are we addressing, what interventions are we going to put to ensure that women, there is the gender transformative response to TB in countries. And I must appreciate that Kenya, my country where I am from, we managed to conduct these CRG assessments and we got the results. But I will now jump to what else we need to do. Research has been done. Recommendations have been made. How do we implement those recommendations that have been made? We need to do, again, advocacy for resources to ensure that we go beyond the research, but you are able to implement some of these recommendations that have been made. And as a country, and I know this is the case with other countries that have done the CRG, once we get the reports, some of the implementation is supposed to, some of the recommendations are directed towards the government, and some can be implemented with donor funding. We need to do advocacy for the resources to ensure that those recommendations are done, are implemented. Next, we are also very good, and we all know that the civil society, in ensuring there's community engagement in these processes, even in ensuring the gender transformative approach. Therefore, we need to mobilize infected and affected communities at the country level and also at the global level, because it is the wearer of the shoe that knows where the shoe hurts most. Therefore, we cannot do any intervention if we're not bringing on board the women. Here we are talking about the women. The women who have suffered these inequalities are not involved in the response. Therefore, as civil society, STF, let's ensure that there's community engagement and the communities have the platform to do this. And finally, we know how to really hold leaders accountable. We need to look back, what commitments have leaders made in the past that have promised to address these inequalities in accessing TB services? What commitments, for example, in the UNHLM commitments, did the leaders commit to? Even at the country level, what are the strategic plans saying about these inequalities? Are they being implemented? As civil society, we also should be very vigilant to ensure that we are holding the leaders accountable to this. And in summary, I am looking for a civil society that really pushes for TB programs that are gender sensitive and that address specific needs to overcome the barriers. We are looking to advocate for policies that address the harmful gender norms that ostracize women and hinder them from accessing the services, and a world where donors and development partners are investing in adequate funding to address the obstacles that we have talked about. And of course, a world where there's high-level sustainable political will for gender transformative policies to remove the discriminatory laws and policies. And finally, I want to really appreciate all the development partners and donors that have in the past supported this sort of approach, starting with USA before. So thank you so much. Back to you, Blessy.
Thank you very much, Evelyn, for highlighting the role and the comparative advantage that civil society has in terms of ensuring implementation, in terms of deciding what next. We have this what next, and for articulating that very, very strongly. And thank you very much for being on the panel. Over to Teresa now.
Yes, thank you. Thank you. And now clock is ticking and we are close to the end of our session, unfortunately. And I would like to, with pleasure, give floor to our last but not least speaker, Amrita Daftari, Assistant Professor, School of Global Health from York University. And my question to you will be, please tell us, Amrita, what can be learned from the research undertaken on gender and equity considerations in the TB response in countries? What do you see as research priorities to booster this area? Please.
Thank you so much, Teresa, and thanks to you and Blessy for having me on this panel. Happy International Day, everybody. There is really so much, I think, to say on this topic of gender and TB research. But given the time, and I'm going to make 3 points, I think 3 things that we've learned and where we can go from there with regards to research, drawing very much from a call to action that was recently published in the Grey Journal that I was really proud and fortunate to be a part of, and also sort of piggybacking on some of the points that have already been made by this amazing set of panelists. I'll say first that gender-based research in TB has largely focused on the burden of disease in women and men and disaggregating program indicators that are routine by sex, with a focus on percentage, with a focus on physical impacts. So where do we go from here? Well, we've got to zoom in on the vulnerabilities and the faces that underlie those numbers. We've got to stop pitting the genders against one another when it comes to investing in TB research and programming. We're looking at a disease that's affecting 10 million people a year. There is absolutely no ratio that could justify omitting attention to the unique needs and vulnerabilities of women and men. There is none. Second, we know that a woman with TB is a woman first and a person with TB second. So in most TB affected settings, we're looking at women who are facing social and material inequity, entering the TB care cascade at an immediate disadvantage. And most healthcare systems are simply not set up to be responsive to that disadvantage. And that disadvantage only worsens given the stigma and the fear that is attached to TB that we've seen in the stories that we've heard today, particularly from Farah, who, like, congratulations, thank you so much for speaking up. So where do we go from here? Well, I say we need to set the playing field straight. In sports, we give disadvantaged athletes a handicap to equalize their chances of getting to the finish line. What an unfortunate term, but there is something that we could learn in TB. What can we do to level the playing field for women so they have as good a chance of making it to that finish line? Our goal for research has got to be focused on equity. We can't settle for equality. And we've got to figure out a way to do this while supporting the dignity and power of women. Because as a species, ultimately, we're fierce and we're fiercely resilient. No matter what comes our way, eventually we figure it out. Eventually, even if the process strips us of everything we have, we do figure it out. So research really can make an important contribution here if we really focus on what matters most to women. We're obsessed with data and research and evidence. Well, if that's what our obsession is, then let's systematically collect the data that matters to women most. For women, this might include the impact of TB and medicines on their menstrual cycles, on their fertility, on their fetus, on their physical appearance, on their mental well-being, and the duration of those effects, over and above whatever is routinely collected. We equally need big data on the non-clinical consequences of TB, which has already been shared by some of the speakers today. Loss of access to household resources, partner or family rejection, educational outcomes, violence, disrupted contact with children, as well as all of the positive things such as family support and repatriation, which we know matters so much. And then we've not got to sit on it. As Evelyn mentioned, we've got to act on mobilize this knowledge to inform every clinical encounter with a woman and to inform the social protections around her, including economic protections and educational protections. Because if you've set those things straight, you've already developed her resilience to manage the stigma that she is going to face. The other data we need, I would say, is not specific to women, but it's very relevant for them because it could help to reestablish some of their social status that gets lost because of TB. We need translatable research about TB infectivity. Almost anybody with HIV, and Dr. Harder will know about this, lives by the motto U equals U, undetectable equals untransmissible. In TB, we've got to have the courage to apply the tools and the knowledge that we already have at hand and make it available to patients and let them know when they become non-infectious just as quickly as we're ready to tell them that they are infectious. And if this means spending twice the number of expert cartridges a month on verifying that information for them, well, so be it. Let's pump the resources to translate the research that we know to enhance the dignity and quality of life of women with TB. Lastly, I'll just end with this idea of being inclusive, as we've already seen from many of the panelists' messages from the get-go. Engage the FEM lens when developing TB programs, when developing TB innovations. And this means financing those initiatives and finding the expert bandwidth to include women, particularly those of childbearing age, pregnant women, women of diverse gender identities in technology development, in clinical trials, and in social research. This very Neanderthal vision we have of protecting women and girls has also become the perfect excuse to exclude them and to marginalize them further. So I'll just end by saying, let's choose to challenge the status quo and to apply a gender transformative thinking and lens in TB research. And I raise my hand in solidarity. Thank you.
So thank you very much, Amrita, and for your kind of wish list. But this is not wish list. That all these things are doable, they're possible, and they can bring a new energy to our response. And indeed, it's time from the points of we all know what should be done, how it should be done in the most effective way. So thank you very much. It was very important point at the end of our discussion. And so time is running very fast. We had more than 125 participants in our webinar, and it clearly showed interest to this topic. And we should definitely continue, and we will continue. We've received many positive greetings and points in the chat, less questions, but still there are questions which should be addressed, like people raised the issue of the settings, vulnerable settings as Cox's Bazar, and groups of people. And I must say that I've personally, before this lockdown, visited, and it's a heartbreaking story, and already many UN agencies are working all together, but of course it's not enough at all. All the efforts should be doubled, especially now when in the COVID pandemic situation, so it should be definitely continued. And so we are closing today our session, and first I would like to give a floor to Blessy. Blessy is a real passionate leader. She is taking all the pains and all the sufferings of people so close to her heart. That it's really it's an excellent example. I'm learning personally from her and from her wisdom, from her experience and passion. And Blessy, floor is yours for closing remarks.
Thank you very much, Teresa. While it has been extremely encouraging to hear all this, I also want to say that we have a lot to do on the ground. Just 2 days ago, while I struggled to get a young woman, a tribal woman in India, diagnosis and access to treatment for her TB of the spine, a gentleman told me, oh, but it's just one small case. Why are you worried about it? For me, it's not one case, it's one life. Farah wouldn't be sitting here today if her mother hadn't supported her, if the system hadn't supported her. So in ending, these things trouble us on a daily basis, and we cannot do it alone. The Global Coalition of TB Activists, we struggle on a daily basis, but we need your support. We need the support of WHO. We need the support of Stop TB Partnership, USAID, Global Fund, UNAIDS, researchers like Amrita, civil society representatives, and most importantly, at the heart, people who are suffering from TB, who have survived TB. We need to work together. And unless and until we do the support, we are not going to get there. It'll be just young women will continue to die. Women, men, children will continue to die, and they will become a number in our statistics. So today, I really want to thank you, Teresa, for joining with the Global Coalition of TB Activists to put this webinar together. We are just a small affected community coalition, but with your support, we have been able to reach out to these powerful women, and that's how the power dynamics change. And I want to thank from the bottom of my heart each and every person who's been here and shared so amazingly, and for all the other attendees, more than 125 people who joined us, and a lot more, hundreds more who are watching us on Facebook and YouTube. Thank you very much for being with us. A big thank you from me on behalf of the affected community. And thank you so much, Teresa, once again. Thank you.
So thank you very much for our partnership, for amazing collaboration. We are all together and should be even closer in this fight against still one of the biggest killer in the world, TB. And I would like to thank once again our panelists. We know that you are all very busy people, but you've dedicated your time. It means a lot for us. And let's continue working together. And I would like just to end this seminar with close with the words of one well-known, passionate leader who is man. And I'm privileged to work under his leadership. And he is addressing today these words to all of you. Dr. Tedros, WHO Director General. I wish all women, as well as the men and gender diverse people who support them, happiness and health on this day. You are an inspiration to me, and I hope you are an inspiration to many girls and boys around the world. Congratulations to you all on your achievements over the past year as we work together to bring the COVID-19 pandemic to an end, and to bring to an end all other pandemics, and as TB is one of them. Thank you very much, dear colleagues, to be continued.